We will forget how to value or recognize the role of the artist who responds creatively to the cosmos, to grasp it in terms that can speak to others. In giving up this process, we diminish our humanity. We settle instead for the mere pressing of a button whenever an evocative conceptual picture is needed. By making clear these distinctions, but art requires a conscious agent, that AI is not conscious, that conscious awareness is not computation, but artificial intelligence, being computation, is simulated intelligence, that unlike AI, the artist is a participant in the universe that she describes, that her work is a creative response to this cosmic domain, that her work is a necessary feature of the human dilemma, then we can be reassured that AI cannot replace the human need and reality of the artist, the need for a new model of decision-making. Current models of medical decision-making often take the form, at their root, of algorithms that represent data as the given elements of the decision, and their logical coherence as their inherent structure. From this, a decision tree is constructed that shows all possible decision points and their probable outcomes. One presumes that a computer tool, based on such an algorithm, in that it contains the essential elements of the medical decision, is able to make the decision in lieu of, or on behalf of the clinician. It is true that an algorithmic decision tree can serve as a useful prop for the decision maker. It can make explicit the elements of the clinician's creative response to possibility. But this objective structure contains no representation of the creative process itself, whereby such a decision tree comes into being. Therefore, such a model will not do as a tool for medical decision-making, for it is missing the creative element. Without this creative interface, a computer tool will impede the decision-making process. It will force the clinician to turn away from the lived possibility as it is perceived in the patient, so to accommodate the static elements of the algorithm, to defer to them. It is true that the mature clinician will come to anticipate that every objective formulation, such as a diagnosis or treatment plan, is provisional by its very nature. That is, the formulation is temporary, not because it is imperfect, but because it exists to serve an end beyond itself. Still, the clinician will be tempted to defer to objectivity, as represented in the decision tree, as if it contains the sufficient conditions of the medical decision. To counteract this temptation, it was sufficient in the early 20th century for Dr. Francis Peabody to say to the class of Harvard medical students that the secret of the care of the patient is in caring for the patient. In Peabody's time, relative to today, there was little that could be done for a seriously ill patient, except for support. This meant that ample time remained for bedside manner and for the art of medicine to erupt spontaneously. Today, however, after 100 years of emerging medical technology, there remains little time or mental space for bedside manner. The mere existence of actionable medical technology renders it standard of care, so that the weight of scientific consideration becomes a distracting burden. In lieu of a compelling reason to make room for the clinician's subjective impression, this essential element of decision-making becomes a casualty of technology. The doctor-patient interaction no longer occurs by default, as it might have done in Peabody's day, as the computer pulls the clinician away from the bedside. One still pays lip service to the notion that the agenda of medicine is caring for the patient, but the scientific rigor of evidence-based medicine has replaced empathy as the central dogma of medical care. The hypnotic illusion of the object as the end in itself has replaced the sense that the pre-objective doctor-patient interaction is primary. Without a model of decision-making that explains how objective knowledge is dependent upon subjective impression, the clinician is left with no theoretical wedge in defense of the doctor-patient interaction. There remains no reason to talk to the patient. A feeble attempt was made in the theatre century to rectify this defensively by introducing the notion of the biopsychosocial model of medical decision-making. This so-called model served to remind the clinician that there are subjective elements of decision-making, but the biopsychosocial mantra is not a true model. It acknowledges the eclectic sources of the medical decision to make the clinician aware of them, but it does not explain their interaction. It renders no tangible direction to the clinician on how to navigate from subjective impression to objective formulation. It does not materially defend the clinician's beleaguered impulse to make room for the doctor-patient interaction. The inevitable result is that the biopsychosocial model has given way to stronger forces. As the complexity and volume of scientific knowledge increases, and as the exigencies of practice management make increasing demands, the clinician is forced to choose objective formulation over the more primal and time-consuming doctor-patient interaction. The emergence of evidence-based medicine, the model that arose to support this deference to objectivity over subjectivity in decision-making, is called evidence-based medicine. In evidence-based medicine, objective data are construed as the given predicates of a logical proof. The logical necessity of the derived proof is then taken as the necessary truth of the resulting formulation itself. By this evidence-based model, fidelity to objectivity appears as the sufficient condition of the quality decision. For this reason, evidence-based medicine brings the medical decision to a premature close. That is, since the decision appears to be based on given data as evidence, it appears to require nothing outside of this formulation. It is no longer open to the pre-objective domain of possibility that is accessed as empathy in the doctor-patient interaction. It is true that rigorous evidence-based formulations render to medicine the benefits of the scientific method, measurability, reproducibility, statistical certainty, and falsifiability, testability. Evidence-based decision-making also rescues medicine from the tyranny of historical and institutional authority by rendering the clinician responsible for demonstrating the elements of the clinical decision. But the model of evidence-based medicine also preempts the creative impulse. The clinician may not feel compelled to turn away from the computer screen to engage the patient. The medical decision may come to a premature close in the name of its mere objectivity. An effective model of decision-making therefore must begin with acknowledgement of the background domain of possibility. From this starting point, one then can describe the creative process whereby an evidence-based logical proof emerges in response to subjective perception of possibility. We have called the elements of this creative model possibility theory and metaphor induction. Possibility theory does make room for the role of evidence-based formulation, permitting it to appear to the decision-maker as the end in itself. But it demonstrates, through metaphor induction, that these objective formulations are derived from the subjective impression of possibility in the doctor-patient domain. Evidence-based formulations thereby can be understood as products of, and therefore as subordinate to, the primary impression of open-ended possibility that is the milieu of the doctor-patient relationship. The art and the science of medicine. The mature clinician will develop a sense of her subjective role in the art of medicine, even as she can see only the objects of medicine in front of her at any one time. These two arms of the decision come together in the moment of discovery in the medical decision. For instance, an elderly woman may present to her doctor with a complaint of swollen, edematous legs. Her doctor might attribute this finding to the failing of her heart in its function as a pump, in the transfer of blood from her legs to the rest of her body. This application of the pump metaphor does not appear to the clinician as a metaphorical grasp of possibility. Rather, it appears as the grasped possibility itself. It appears to be discovered as given. In this moment, the art and science of medicine come together. Understanding the act of discovery, simultaneously from these two perspectives, as a creative metaphorical grasp that nevertheless appears as given, uncovers the connection between the art and the science of medicine. The creation of the object, through the application of metaphor, is the art of medicine. The appearance of this metaphorical grasp of possibility as the grasped possibility itself is the science of medicine. Thereby the art and the science of medicine merge in the moment experienced as discovery. By means of this hypnotic aspect of metaphor application, the clinician's devotion to possibility is transferred to the created object itself, as if it were the end in itself. This illusion is necessary to precipitate the subject-object interaction, whereby intended possibility is actualized. This is the reason that the art of medicine remains occult in the moment of the medical decision. Good faith medical decision-making. For the clinician who feels bound to evidence-based medicine as a sufficient condition of quality medical decision-making, there is no escaping the disconnect between the art and the science of medicine. He might feel an artistic impulse in response to patient need, but the evidence-based script with which he works will awaken in him no acknowledgement of a creative responsibility. All he will see before him is the objective formulation as the end in itself. This creates the conditions for a moral hazard that can be expressed in Sartre's terms of good faith versus bad faith, as this pertains to perception of possibility in the clinical setting. Devotion to objectivity in good faith is devotion to objectivity for that end for which objectivity has come into being, the grasp and actualization of possibility. In this case, The decision-maker will remain responsive to the milieu of the doctor-patient relationship as the source and final arbiter of the medical decision. A devotion to objectivity in bad faith, on the other hand, is devotion to objectivity as the end in itself, as the sufficient condition of the medical decision. In this case, the user will fail to return to the milieu of the doctor-patient relationship. This is characterized by a premature closure of the medical decision in the name of near objectivity, and frustration on the part of the patient. Distinguishing good faith from bad faith decision-making is difficult because both manifest overtly as devotion to objectivity. However, one is a devotion to objectivity as the means to an end beyond itself, while the other is devotion to objectivity as the end in itself. Good faith decision-making decides itself in the existential courage to return to the patient bedside, to respond with creative reformulation of the evidence-based decision. The medical ethic as a social paradigm. In this way, the medical decision requires the clinician to step courageously into the horizon of open-ended possibility, to respond creatively for its actualization. Herein, the activity of the clinician is a paradigm of the agenda of medicine as a social institution. Society cannot hide behind an objective standard in the name of objectivity itself. This is true for any ideology that can be made into a plan of orchestrated behavior. Just as in the case of the physician, the citizen may experience an uneasy ambivalence in response to the realization that every aesthetic, scientific, social, or political system exists ultimately as an existential choice. As Tillich said, social decisions ultimately are, quote, rooted in courage, close quote, for they must render up their claim to being the truth in itself. This realization empowers the clinician, and similarly the citizen, to harness perception of human possibility as the ground of social behavior. Ultimately, this will require our demonstration of how all objective formulation arises as a creative grasp of open-ended possibility. In the next chapter, we will describe this creative process, called metaphor induction, as it applies to the individual medical decision and anthropologically to medicine in society.